So the first speaker again being Dr. Jörg Neugebauer. Please give him a round of applause.
Thank you for your kind introduction, and my topic is now to speak about the possibility of the patients, how they occur in our daily practice. So if we look to our patients, we see that we have democratic change, especially in the industrial countries. Our patients becoming more elder, they have also a higher life expectancy. When I start my implant career, it was really seldom that you treat an implant patient who was older than 80 years. Today, it's mainly always patients in this age range, but also we have seen that these are more vulnerable, and we have also quite a large amount of modern medications, which also influence the bone healing and the course of osseointegration. We discussed these topics, and I'm really happy that Joanne is also with me here with the Academy of Osseointegration's last summit in 2018, where we were especially looking on the various effects on the course of osseointegration. On the other hand, we have to look on the patient's demand. So they request not to have another surgery, especially if they are very old. They want to have only a few appointments. After tooth loss, they request a very quick retreatment, and also they want to have not so much interventions. And on the other side, they are not earning as much money as they did in their business life, so the treatment must also be cost effective. So how do we now deal with a patient if they show up in our office? So first, the patients come in our office, and then we have to clarify their expectations. We have to get their data. We have to speak with them, and finally, we have to look for a consent information so that they are ready to get a treatment. Which data do we need from the patient? We need the X-rays, so we have to look where are the teeth missing, which teeth will be not restorable, and we have to do the clinical examination. Quite often there we have seen not so favorable situations. They are really compromised. We have to do all these documentation, and here we also get a large amount of data which we have to collect and to store in our office management system. These data are very easy to keep because it's a small data volume, but on the other hand, then we're getting more and more data, which large file size. If you look to the intraoral scan and also to the cone beam CT scan, where we get also more detailed information, that finally we have the possibility to have the treatment decision and to know what we want to do. Looking we now on this patient, we have just seen here at the situation where he will lose his central incisors in the lower jaw. We have to do a cone beam CT scan, and now looking for the amount of bone. And if we look to the literature, we quite often have the discussion that on a cone beam CT, we have not enough information to determine the bone quality, which available bone we can see quite easily how much grafting procedures we need, but we also have here the possibility by evaluation of the gray values that we have also here a dense bone situation or less dense bone situation, and also there we can look to the data that we have similar like on cone beam CTs, possibility to look on the bone quality and also prepare our case, for example, to do an immediate restoration. Especially if we see these patients then in our office, sometimes it's really difficult to explain them how to use a toothbrush. We have to involve them also in a periodontal program so that they can keep their remaining teeth, but some teeth are just hopeless. They're already stabilized, so we have to remove them. If we are be able to keep them in a regular recall program, we have also good prognosis for the long-term run, and we can start with our treatment plan. And I'm really happy to work together with products from W&H and Osstell, because they are now combining more and more. And so we have now a reliable preparation of the implant preceptor sites and have this also in one machine so that we get enough torque and enough power, especially if we have to do the preparation in the anterior mandible, where we quite often have a dense bone structure and we need enough torque for the treatment and for the preparation of these implant sites. Finally, we do the implant placement, and then we need again a precise machine that we get a precise torque and that we can also evaluate the stability of the implants, especially if you want to go here for immediate loading procedure. Implant stability is a very long used term in implant dentistry, but also we have to see when can we do the measurements and how we can do the quantification. So the insertion torque is quite often mentioned, but also we have to see what is the reliability of this insertion torque, which torque range are we using to check these torque to get the right information. Other possibilities are the Perrier test and also the resonance frequency analysis. And just looking on this time schedule from Marcus, I remember my first animal studies at Cologne University, where I had to use wires in these areas with the first Osstell devices. So I have also a very long history with these kind of measurements. If we look to the primary stability, we have also to consider the implant design which we are using. And there are today a lot of different implant designs on the market. And we have to look especially to the design features. Also, if you go down to the exhibit, you see new variations of the ITI system. But all of these implants, they have similar parameters. So we see that we have mostly on all the implants conical parts, we have parallel parts, and we have also to look especially on the crestal design areas in these various design posts. And all these design parameters give us a different amount of primary stability, but sometimes also some tension, too much stress, and this could also lead to a loss of the bone in these areas. So we have not only to consider the bone of the implant design, also the available bone, how much spongy bone do we see, how much cortical layers do we have, and this is also influencing the stability and also the measurements on the stability. So this means especially for the measurement of insertion torque, we have multiple parameters by the implant design and by our receptor sites of each individual patient situation. But on the other side, we have even more difficulties if we look then on the devices we are using. And here we did also some research going back to my time at the Cologne University, where we used these torque measurements. And on the first measurements, on the first measurements, we were looking here just on various surgical motors using the handpieces with these devices and doing the measurements. And at this time, I was really surprised how large the variation of the different measurements could be, so that we have deviations from the Z torque. Sometimes it was below the Z level, sometimes above, and here we see a deviation in some instruments for about nearly 1/3 of the Z values. This is also a danger because we do a measurement, we think we are on the right side of our treatment, that we have the right and appropriate insertion torque, but we get false data. We continued this work and we had done another study on this topic, and there we are doing a doctor thesis and setting also these other machines so that we've seen even larger deviations. So up here to more than 50% in these devices, and this is also then a very high danger. But it becomes more and more complicated because if you are using a surgical motor and not using the system handpiece, because then the deviations become even more complex, and so we have seen a large variation, and this means that we nearly cannot measure data if we are not staying in the correct system. So we really have to check how the accuracy of the implant insertion torque is determined by the surgical motor, by the surgical motor and the used handpiece. Also, we have to check the maintenance of these devices because if they are not enough cleaned, then we have also the difficulties that these measurements could be even worse. So we have the situation that if you like to measure the insertion torque, you always have to stay in one system with one motor and the corresponding handpiece so that you get the best values. And here we have now seen also in our study that the most appropriate measurements were done with the Implant and the W&H handpiece. So the other opportunity, as already mentioned, is then the use of the Osstell device. Here you see now especially the very good situation with the color coding, so that we get now here a green light, which means that these two implants are placed with an Osstell value in the mid-70s, and they are stable enough now to be placed for an immediate restoration. In an office working with a digital workflow, we have now the opportunity to do an intraoral scan, and so the scan is also very appreciated by our patients because we have a much better time reduction in these situations than working with conventional impression, and especially if we are doing these impressions by the optical scans, it's much better in the digital workflow because here we have not any contamination with the impression materials in this surgical field. It's important, especially for immediate restoration and the flapless procedures, that we take enough radiographs, like you see here, the scan post on the correct position, so that we are also able that we have the right placement of our scan post and also a reliable production later on our digital models. We have to continue our workflow, and until the superstructure is now manufactured, we are placing the gingiva formers, and here I also like to work with a machined driver, because here we have then the opportunity to place the gingiva formers with a controlled insertion torque, and then we have the final situation, and we do another scan of the soft tissue situation that our lab technician has a possibility to do the ideal management of the temporary restoration. For the first initial treatment, we do very simple prosthetic rehabilitation. We use a vacuum stand, fill it with some acrylic material, and so the patient can leave our office, and on the next morning then we have the possibility with our lab technician to do the delivery of the temporary. On the lab situation, we have now the opportunity in our office that we have our own printer, we have our own milling machines, and this also improved the speed for the production of these temporary superstructures. So the production of the casts is also very important, that we have a printer with a very small offset for the implant analog holders, because then we always have a higher precision by printing these models with a different resin. And it's also important that we consider the right design of these models so that they are stable enough for a well precision. Our lab technician then uses corresponding components, and they have now to do the design of the superstructure. And also here we have seen a transformation of the lab technical work because we have now different data available. So we have the scan prior to the implant placement with the remaining teeth in place. Then the lab technician can design the new prosthesis and can also check these with the various options by overlaying the initial design and the situation prior to the tooth removal, so that we get also a natural-like design of this superstructure. When the design is ready, it's going to the milling machine, and then we have to continue with our lab work so that this is then glued on the abutments, and so the lab technician can deliver this removable bridge so that we have now one piece which is be placed on the next day. So this allows us, especially with these implant systems which have conical connections, that we can seat these directly in the mouth of the patient and it's screw retained, which is also beneficial not to use any cement in these areas, so that we have also less biological complications. Due to the situation that we have used the gingiva former by the placement with the contra-angle piece, we have also a low insertion torque of this component. We can easily remove it, having not any forces on our implants. Then we are mounting this bridge in one piece and do also the torque-controlled delivery of these fastening screws. When we are speaking about immediate restoration, it was always a question, how is the quality of the osseointegration in these cases? And when I did my first animal studies with a lot of data collection, we had then the histological evaluation. And here we could see that we have an improved osseointegration after this initial osseointegration period with immediate restoration. Because we have seen a larger amount of transverse collagen fibers in these cases where we had loaded the implants. Where we had loaded the implants directly, so we had here a better quality of the osseointegration in comparison to the unloaded situation. So it's not a higher risk for our patient to do this immediate restoration, and then after 6 to 8 weeks, we can remove the temporary restoration. Sometimes we leave it longer, depending on the demands of the patients, and then we change the abutments, do a new framework out of ceramics, so that we can finalize now this prosthetic rehabilitation. This allows us a digital workflow in our implant office, which is patient-oriented. We have less chairside time necessary because everything is very condensed. We have one surgery, next day a very quick delivery of the temporary, and so we have also the opportunity by the cone beam CT evaluation of the cases that we, prior to the surgery, can really check which opportunity will we offer these patients. And though we have not large deviation from our initial treatment plan, if we have once made the decision. But it's also important to check the various stages so that we have then the opportunity with the Osstell device to look, is the implant stable enough? Is the osseointegration well enough so that we have also an improvement of our office efficiency? And also this treatment is today scientifically evaluated, and so we can offer our patients a modern dentistry. Another lady showing up in our office, and here she had already lost some of her molars, but she is somehow satisfied, but on the other hand, she is now recognizing that her teeth are becoming more and more mobile in the anterior situation. Again, we continue with our routine procedure, doing a cone beam CT for the detailed evaluation of the anatomical structures and to do also the prosthetic-driven implant treatment plan. So here we have now our template with the available implants for this individual situation, and this allows us now to do also the fabrication of a surgical guide. And the surgical guides we quite often use first together with our lab technician. So we have also here a very strong interaction between our lab technicians and the clinical site, because these surgical guides are now used to prepare the temporary, so that we have here at the beginning of our surgery already the temporary solution available. So we do the tooth extraction. We have here the opportunity to stain the bacteria with a blue color. So we have the possibility of the photodynamic therapy, to have also the risk reduction for the healing of the extraction sockets. And then we do the pilot drills to get the correct direction for each implant position. If we are doing these angled implant treatment to avoid large augmentation procedures, we have here also the opportunity to do these cases complete flapless, so that also here we have less morbidity, and the patient are really happy, because they were afraid to lose their teeth, they are afraid to have a large amount of pain, and on the next day they recognize they have new teeth, and it's also not so painful after all, because we had not the necessity to raise large flaps. Also here we do the seating of the implants with a corresponding insertion torque, but also it's important to double check these insertion torque and to do again the measurement of the resonance frequency analysis technique, so that we check how stable the implants are. If we have an implant in the row of 4 or 6 implants which has not the highest ISQ values, so we can combine them. We have a good splinting with these temporary restoration, and this allows us also the possibility to get a good and successful osseointegration. So in this case we had now 6 implants in the maxilla, and the average of the resonance frequency analysis values was above 65, and so we have also here stable situation. We do now the fixation of these temporary directly at the end of surgery with some resin. It goes back to the lab technician. He does final adjustments, and then we have also solved this case. Coming to my last case, it's also the question how we can improve the grafting techniques if we have not so much bone available. And so this lady lost here in this situation her last molar. It looks not so bad. Also the discussion for implant placement here in the upper left jaw. But then the big surprise after the initial preparation of this case, because now we have to recognize that we have not enough bone here in the area of the second premolar in the lower jaw. In former times, my decision treatment was then first to do a lateral grafting, wait for about 2 to 3 months, and do then on the second stage the implant placement. Today we have now the opportunity to match the optical data of the intraoral scan, like you see here with the brown and the orange color of these 2 designs. So we have our prosthetic goal as one STL file matched with these cone beam CT scan, and we can do now a patient-oriented treatment plan for our ideal position of the implants. And everyone who is using implants in the posterior would recognize that it would be extremely difficult to do this situation freehand because we will have not the opportunity to place these implants in the correct position due to the deviation of the cortical bone in these layers. By the modern software for doing these implant planning, we have now also the opportunity to get an AI routine to make us these surgical guides. So it takes about 15 minutes if I upload these data to the server, and then I get these design back where I now can send this to the digital printer and get these kind of surgical guides very quickly available. This is, I think, one of the major improvements because we have a possibility of a reduction of these preparation time so that we get these data quick available. So now we have the clinical situation. We now raise a flap. We have now the possibility to do a combined preparation for the implant placement and also for the lateral grafting. Initially, you have to check the surgical guide. Then we have our fully guided implant site preparation. You see, especially on these cortical positions, it's not always easy with a burr to get an exact and easy placement, but we have a good guidance. And you see also we can collect the bone chips by the implant placement. Here I decided to do the implant placement freehand because we have very good guidance in this cortical bone. I check the primary stability after I have placed these implants with an insertion torque of 45 Newton centimeters. You see again the green light so that we have here the correct position. Now the cover screws are placed, and on the second part of the surgery, now I harvest a bone block. Here I use the same surgical unit, so we have two possibilities. One is to do the cutting with the drills, and on the other hand, we have the opportunity with the piezo surgery to remove then these blocks. So now we have this small block which can be then removed from the retromolar area. We have these available. I use a small diamond disc, so this is also very easy because I can switch with the foot pedal to the two different devices, and now I can cut my bone block in this area, make some holes, and then it will be fixed with some osteosynthesis screws. Now with this small bone block on the lateral side, I have enough stability here for my further lateral grafting. So I'm now building a cage where I can put further particulated bone. So the fastening screws are placed here by hand. This is still a little bit more tactile, especially these very small 1.2 millimeter stainless steel screws are placed now in this situation. And then we have here the volume generated to do the lateral grafting. The remaining bone from the bone harvesting I smash with this small instrument. I get this peticulated bone. A few mallet taps increase this altogether. Then I mix it with the bone chips I collected and also wetten it with some further blood from the surgical site. So I have enough autogeneous material which I can place then in these areas. This lady also requested not to use any foreign material, which makes the case also a little bit more sophisticated, that we had enough bone harvesting in this area. I put it around, and then we have to do the flap release and the suturing of this situation. So a close tight wound closure is always important for the best long-term run, so that we have an uneventful healing in these situations. And due to the possibility that we just work with one medical device with two options for the piezo surgery and also for the drilling, we have now here the optimal situation. So here the post-operative situation that we have now done 2 surgeries in one appointment. You see the osseocentesis screws. We should remove them prior to this meeting, but the patient was ill, so I have to do this on the next time. So if I look to the patient journey in my daily practice, it's a digital success due to various parameters. So first we have really careful select the ideal patient. So we have to look what are the requirements for this from these patients, which is the best treatment options. And here we have a large variation today available. We have also to look which kind of material will we use, which devices, but we also need a trained staff, and we have also to consider the right hardware and software so that we can do our work on an ideal situation. You have here again this QR code so that you can answer that as we go with the questions remaining to my presentation, and I would be really happy to see some of you next year in Seattle on our first 40th annual meeting, which I'm then hosting as the president of the Academy of Osseointegration. Thank you very much.